Hi, everyone. You have joined us today for the Mountain States Regional Genetics Network Time for Genetics webinar. We are so excited you're here. Thanks for joining us today on this Thursday. The topic for our webinar today is on developmental delay and genetics. And we are happy to acknowledge our funders first for the work that we do here at Mountain States. So this is our HRSA funding statement. This webinar is supported by the Health Resources Service Administration of the U.S. Department of Health and Human Services. I also have our CME statement here, and we'll give some more information about this at the end of the presentation, so stay tuned for that. And with that, I'll just give a brief introduction of myself. Hello, I'm Christy Leese. I'm the projects manager for Mountain States Regional Genetics Network, and today I'm joined with Cody Price, who's our state teams coordinator. You can find both of us in the chat if you need technical assistance. Our logins start with MSRGN. So if you look in the list, you'll see the little DNA symbol and our logins there to message us if you need to. Just a couple of Zoom logistics before we get started. We are asking everyone to stay on mute during the webinar. So if you're not on mute right now, if you could put yourself on mute, that would be great. And also feel free to turn your camera on if you feel comfortable, but please just note that we are recording this for archival purposes. So you will be recorded if your camera is on. This is also number 3 here is the active participants list. And number 4 is the chat feature at the bottom bar. So if you do need to have any technical assistance, as I said, during the presentation with Cody or I, you can find us with our names starting with MSRGN. So those are just a couple of the Zoom logistics, which I know we are all getting so familiar with these days, but just wanted to go over those. So this presentation today is part of our Time for Genetics initiative. This initiative is a pediatric primary care genetics education initiative in our 8-state Mountain States region. This is in our first cohort, we have 7 clinics participating in this program across our region. And you can see the pins there on the map of where those clinics lie. The application is now open for until November 15th. We are recruiting right now for cohort number 2. So if you or someone you know, maybe in a primary care clinic, a pediatrician's office, and they might be interested in participating, please send us a message through our website, or we will also drop the link to the application for our Time for Genetics program in the chat in just a moment. With that, I would love to welcome our guest speaker today, Dr. Austin Larson. Dr. Larson is an assistant professor and works in the Pediatrics Clinical Genetics and Metabolism Department at Children's Hospital of Colorado. He's also the program director for the Medical Genetics and Genomics Residency Program at the University of Colorado School of Medicine. And with that, I will share the topic, the title of his slide here, title of his talk here, An Approach to Genetic Diagnosis for Patients with Developmental Delay. And with that, I'm going to turn it over to Dr. Austin Larson.
All right, thank you, Christy. I will share my screen here. All right, so I'm excited to be back and talking in this forum. I'm really honored that a lot of you have chosen to spend your lunch hour here with me and hear what I have to say. So my goal for this talk is to kind of start back in 2018 when this group, the Mountain States Regional Genetics Network, developed an approach to genetic diagnosis and developmental delay position statement or algorithm. And our goal with that was to make genetic testing more accessible, to empower people outside of the genetics clinic, maybe in a primary care clinic, in a developmental pediatrics clinic, in a neurology clinic, to take some steps to try to identify genetic diagnoses in their patients. And the basis of those recommendations was the consensus statements that had been put out by the American Academy of Pediatrics, the Academy of Neurology. A number of other entities had pretty similar recommendations for the approach to genetic testing for a patient with developmental delay. But a lot has changed in the last 3 years. And even at the time that we put the algorithm together, we knew what changes were coming, and we knew that that would have to be a living document and something that evolved over time. So what I want to talk with you about today is why the approach is evolving, why there are maybe some differences or some deviations from the recommendations that we put together in 2018 that you probably have already seen for your patients that have been referred to a genetics clinic or a neurology clinic in terms of how those providers have approached testing for developmental delay. Or maybe you've called for advice. You've called your local genetics providers and asked what they recommend. And maybe they recommended something different to you than what was in that statement. So my goal is to go over some literature from the last few years and to demonstrate why I think it is appropriate now to deviate from that algorithm. And just to give you a preview that we are currently in the process of revising that algorithm and making new recommendations that will be in line with some of the recommendations from national groups, including the American College of Medical Genetics. So before I dive into the details of the algorithm, I think it's really important to take a big step back and think about what are we trying to accomplish in the first place by attempting to find a genetic diagnosis. And really, the primary goal that supersedes everything else is to try to identify patients with treatable conditions and to intervene in a timely fashion. That is the basis of a lot of diagnostics in medicine, not just genetic diagnostics. That's the basis of newborn screening. That's the reason for a lot of the imaging studies and other lab tests that we get. So that's a pretty universal kind of precondition for diagnostic evaluations throughout medicine. But I think it's important to keep that in mind. Some things that are a little bit more specific to genetics are to resolve uncertainty for families and to prevent the need for additional invasive or expensive diagnostic studies. So sometimes finding a genetic diagnosis that can avoid a biopsy or a sedated imaging study. It can avoid the need for traveling long distances to see a subspecialist. Additionally, finding a genetic diagnosis can give people prognostic information that other types of diagnostic testing can't provide. So there are times in which a genetic diagnosis does convey a progressive course to a disease, which is unfortunate, but that's important information for families to have for their planning. Lastly, a genetic diagnosis, unlike almost any other category of diagnostic evaluations, can give us information about recurrence risk for a family. Is there a potential for another child to have the same condition as the child that we're evaluating? So those are our overall principles. Those are our goals. That's why we're doing this in the first place. So the question then for us is, what's the best way to accomplish these goals? How can we find the patients that need treatment as quickly as possible? How can we do that recognizing that there are limited resources, that we need to use the resources that we have in the most cost-effective way possible? How can we achieve these goals with the maximum of equity? How can patients with limited means, remote geography, maybe families with cognitive differences, how can we help these people to access the resources that they need as well as possible? And so the rest of my talk today is going to get a little technical at times, but I really want to lay out what I think is a pretty strong case for changing the approach that we've had traditionally to genetic diagnostics. So the primary intended audience for this talk is primary care physicians and non-genetics professionals. I do see a couple of colleagues on the call, and thank you for being here. But I do want to go back and talk about a little bit of vocabulary that I think will help in terms of clarifying exactly what I'm talking about as I compare different types of testing. So almost everyone has probably heard about microarray, sometimes called chromosomal microarray. It's been in wide clinical use for about 15 years. That test really is designed to do one thing, which is to detect copy number variation. Copy number variant is a deletion or a duplication of a part of a chromosome. So that's a relatively larger genetic change in the scheme of things. Exome sequencing, by contrast, has been in clinical use for about 5 years. It's sort of accelerating in terms of the uptake and how often this test is used. It started out being used in only very limited settings, and the application is getting broader and broader over time, over the course of about the last 5 years. The big difference between exome sequencing and microarray is that exome sequencing generates sequence data, meaning it spells out genes, in addition to information about copy number variants. And one of the things that's changed in the last few years is that we have improved techniques for detecting copy number variants from exome sequencing. And we have improved or increased confidence in our ability to do that, and confidence in the ability to rely on that test as it relates to detecting copy number variants. It's not perfect, but it's pretty good, and it's good enough that the exome sequencing test is sensitive for the vast majority of the things that would be diagnosed on the microarray. So we generate the same data. We can call the same diagnoses from that exome sequencing that we could call on the microarray, plus many multiples more additional diagnoses that are only detectable because of the increased resolution down to the level of single bases as opposed to larger segments of chromosomes. Genome sequencing, as opposed to exome sequencing, is just starting to be in wider clinical use. And that generates sequence data, not just for the genes themselves, but also the areas between genes. That gives us an even better ability to call copy number variants. And in a lot of cases, it's better than both microarray and exome sequencing. Genome sequencing really is not widely available. We have a lot of difficulty getting insurance coverage for it. So that's still fairly limited in terms of application, although every indication is that, like exome sequencing, like microarray before it, this will become the dominant testing modality over time. There's a specific type of genetic variation that it's important to comment on. So we've talked about copy number variants and we've talked about sequence variants. Those are two types of findings in the genetic material of an individual that can be diagnostic of a specific genetic disease. There's a third type of variation that we need to talk about, which is called oligonucleotide repeats. So those are areas of the small areas of DNA that are repeated, and if they're repeated enough, then that is a mechanism of disease. And often that requires specific targeted testing technology to look for that particular repetitive area and document how large or small those repeats are. And that is not detectable by the other technologies that we've talked about, although that is changing. And with time, particularly with genome sequencing, we're starting to have the ability to diagnose these repeat disorders using that single kind of broader whole genome test. I also am going to focus on metabolic disease and what's the best way to diagnose metabolic diseases. And the reason I'm going to have a bit of a special focus on that is because that was the subject of a fair amount of debate with the last round of recommendations that we made in 2018 in terms of where does metabolic testing fit in terms of the order of operations for potentially diagnosing a patient with developmental delay. And the big point that I want to make is that metabolic disease is any condition in which impairment of a biochemical pathway is intrinsic to the mechanism of disease. Importantly, most metabolic diseases are not detectable with metabolic testing, or kind of our standard panel of looking for specific metabolites or biochemical markers. Most diseases that meet that definition of an impairment of a biochemical pathway being intrinsic to the mechanism, the majority of those are actually only detectable with genetic testing and not metabolic testing. So that's important for my thought process about the order of operations of how to approach diagnostics. And the reason for the specific focus on metabolic testing is because that has been part of algorithms for developmental delay for years, and because those metabolic diseases are disproportionately treatable or actionable, making those diagnoses has more potential to result in an immediate and active change in the management of a patient. So this is the old algorithm that was the basis of our recommendations in the Mountain States Consortium for how to approach developmental delay. And these stood from about 2010 until recently. The recommendations were to start with microarray, Fragile X testing, and an initial round of metabolic tests. For undiagnosed patients after that initial round of testing, you could do additional metabolic testing, and then gene panels. And later, gene panels really kind of got expanded to whole exome sequencing. But in most algorithms, until very recently, it was clear that exome sequencing was meant to be a second-tier test to be used only in limited scenarios if first-tier testing was non-diagnostic and if there remained a very high concern for the patient. So I'm going to tackle each of these three questions of the first-tier recommendations: microarray, Fragile X, and metabolic testing, and think about whether those truly belong in the first tier, whether those belong in the category of tests that we would do prior to whole exome sequencing. I should also note here that when I say whole exome sequencing, I'm also kind of broadly referring to things that are kind of an exome equivalent. So if you are testing for causes of developmental delay, there's debate about how many different genetic diagnoses can cause developmental delay, but you can make a good case that 2,000 to 3,000 different genetic diagnoses could present as developmental delay. So if you're testing for 3,000 genes, that's really an exome equivalent. So I'm kind of lumping that in with exome sequencing. I consider those to be not exactly equivalent, but pretty close in terms of the approach that we're talking about. So with regards to the question of whether Fragile X testing should be a screening test, meaning should it apply to every single patient with developmental delay, there's been some pushback since these recommendations were made in 2010. And what a lot of clinicians have seen is that the diagnostic yield of testing for Fragile X is quite low when it's used as a screening test. And in particular, there have been publications from genetics clinics, and I'll show you a couple of them, stating that they did not, when using Fragile X as a screening test, they did not identify any patients with Fragile X where there was not also a clinical suspicion for Fragile X, meaning that the test, if it were applied as a diagnostic test in the setting of clinical suspicion, you would not have missed any cases that were picked up by using it as a screening test as opposed to a diagnostic test. So this is a publication from the big children's hospital in Washington, D.C. They found that they diagnosed Fragile X in 2 out of 80 patients with intellectual disability, 0 out of 75 patients with autism. And in both of the patients with intellectual disability that were diagnosed with Fragile X, they had a strong clinical suspicion for that diagnosis prior to sending the test. This is a publication from the group in Toronto. They found that as Fragile X usage increased, meaning as it switched from being a diagnostic test to more of a screening test, the diagnostic yield went down considerably. And this is a publication from 2019. This is a laboratory that found that among 523 cases, 3 of them were found to have Fragile X. And these are cases that were tested for the indication of developmental delay or autism. So that was a diagnostic yield of 0.6%. This is a topic I'm going to get into in a minute, but microarray was diagnostic in 5% of these cases. A lot of these cases went on to a large sequencing test. So this is not exome sequencing, but it's sort of an exome equivalent. Importantly, that exome equivalent test identified all of the copy number variants that were previously identified by microarray. And they found that the diagnostic yield of the broad sequencing approach was much higher than the microarray, double that of the microarray, and much, much higher than Fragile X. So on the topic of Fragile X, there's room for disagreement, but I would say my thought process is that that test should be more of a diagnostic test and less of a screening test. That it should be done in the setting of either family history or medical history for the patient, or a physical exam that is more suggestive of Fragile X syndrome, as opposed to just using that in all cases of patients with developmental delay. I said that the topic of metabolic diseases that cause developmental delay is an important one to me, because I care for these patients in the metabolic clinic, and also because of that principle that we should be disproportionately seeking out those diagnoses that have a specific treatment or management strategy associated with making the diagnosis. So there's a group led by a woman named Clara van Carnebeek, who's now in the Netherlands. She used to be in Canada. She works with an international group of folks on this project called the Treatable Intellectual Disability group, and they have many publications. They also have a very nice app that you can download that will give you a lot of good information, both about diagnosis and pathogenesis of 116 different treatable causes of intellectual disability. And so they, in the past, have been strong advocates for doing metabolic testing in the setting of developmental delay, not because it's high yield, but because it's high impact, that the potential to identify patients with treatable conditions outweighs the other reasons for doing diagnostic testing. And so in the past, this is their new 2021 algorithm, but in the past, the algorithm really was just the left side of this panel here, which was a significant number of metabolic tests, lactate, ammonia, looking at vitamins, metals, amino acids, fatty acids, glycosylation, urine metabolites, and then later moving on to lumbar punctures and enzyme assays and more targeted tests. And they have now kind of revised their position. Remember, these are the folks, and again, my heart is there too, but these are the folks that are sort of most strongly advocating for a metabolic approach to diagnosis for developmental delay. they have recognized that a lot of the metabolic disorders that do have specific treatment strategies, there's no other way to diagnose them other than by identifying the mutations in the genes. There's no metabolite that you can test for. And they recognize that this is asymmetrical. So the genetic test diagnoses all of the metabolic tests, diagnoses all of the conditions that would have been diagnosed with those metabolic testing, plus thousands of other conditions. But the converse is not true. So it's asymmetrical, right? The metabolic tests don't identify any of the other diagnoses, but the broad genetic testing identifies those metabolic disorders plus all the others. So that asymmetry, I think, is really important in terms of thinking about how are we going to use resources appropriately, and how are we going to make this how are we going to make genetic diagnoses accessible broadly, especially in remote locations and locations with fewer resources. So they have acknowledged that it is an equally valid strategy to start with exome sequencing in terms of identifying treatable causes of intellectual disability. Another way to get at that question is to ascertain patients from positive newborn screens. So this is a group in California, and this was a pretty high impact paper. They looked at 674 individuals who were identified as having metabolic disorders based on newborn screening in California. And they took the blood spots from the newborn screen cards and they did exome sequencing on the blood spots, and they saw how sensitive the exome sequencing was for the things that they diagnosed on newborn screen. And the answer was it's about 90% sensitive. So of all of those 674 diagnoses, a little less than 90% were able to make those diagnoses with exome sequencing on those blood spots. So it's not perfect, right? The sensitivity is not 100%, but 90% sensitivity for these specific disorders as ascertained by newborn screen. Again, there's asymmetry, right? So the metabolic testing can't tell us anything about thousands of other genetic conditions, but the genetic testing has at least 90% sensitivity for the metabolic disorders, plus can identify thousands of other conditions. So based on the kind of thought process that I've outlined here of, Fragile X is really a targeted test. It's only testing for one thing. And even though that one thing is more common than a lot of other single diagnoses, that one single diagnosis is kind of a drop in the bucket with respect to the thousands of other genetic diagnoses that cause developmental delay. And recognizing that in the setting of metabolic testing, there's that asymmetry there of which disorders are potentially identifiable with exome sequencing. So recognizing those thought processes and taking into account that new techniques and new analytic strategies really allow us to encompass almost all of the diagnostic yield of the chromosomal microarray with the exome sequence, it really makes sense to just start with the exome sequence that can encompass almost everything else, with the exception of Fragile X, but that's a small number of patients. So this is the first in a series of multiple position papers and consensus statements that have come out that advocated for exome sequencing as the first line test for developmental delay. So one of the major findings of this paper, they found that on average, among a couple dozen publications, there was a 36% diagnostic yield for exome sequencing, which was significantly higher than chromosomal microarray. The other important part of interpreting these data are that almost all of these patients had already had chromosomal microarray, and most of these studies were done at a time when exome sequencing wasn't as sensitive as it is now for those copy number variants, those deletions and duplications that are detectable now by exome sequencing, but before they required chromosomal microarray. So recognizing those changes, they concluded that exome sequencing was appropriate as a first-tier test, especially if the lab that's doing that sequencing can detect copy number variants. And that ability to detect copy number variants has improved with time. This is a relatively recent publication showing 98 or 99% sensitivity of exome sequencing for copy number variant diagnoses that were made by chromosomal microarray. So to state that another way, 99% of the time, if you do an exome sequence, you will make a diagnosis that you would have made on chromosomal microarray. It's only a very small percentage of the time that you're going to miss a diagnosis on exome sequencing that you would have made on chromosomal microarray. And this discussion is really mainly focused on the topic of developmental delay, but the same calculus applies to other things like congenital malformation. So this was, just to give one example, this was a study of congenital heart disease. And the same principle applies for congenital heart disease as for developmental delay. So exome sequencing clearly outperforms chromosomal microarray, and it is sensitive for the vast majority of those diagnoses that would have been made by chromosomal microarray. So the implication of that, again, so now there's a series of position papers that have come out from multiple entities supporting this approach of doing whole exome sequencing as the first tier test. This was a systematic evidence-based review. They came across, unfortunately, only one randomized controlled trial, but over 100 other papers that discussed the yield of exome sequencing. And based on that systematic review, they came to the conclusion that was clearly the right approach to this diagnostic scenario. This is an even more recent guideline. So that was a systematic evidence review, and that systematic evidence review supported this practice guideline. So this is the American College of Medical Genetics. They state that the literature supports the clinical utility and desirable effects of exome sequencing or genome sequencing on active and long-term clinical management of patients with congenital anomalies, developmental delays, and intellectual disability, and on family-focused and reproductive outcomes with relatively few harms. So the fact that they focus on harms is an important point that they make and that they looked for in the literature. One of the things that has held us back and prevented us from applying exome sequencing more broadly is the question of how often do we get incidental findings or uncertain findings that cause harm to families? And that's something that we worry about a lot. We take it very seriously. We in our pre-test counseling and our post-test counseling, that's one of the major focuses that we have, is to prevent harm that comes from incidental findings and uncertain findings. But there's very little evidence in the literature that those harms exist. So I would say that we maybe allow those potential harms to prevent us from doing the broad testing that we should be doing in some cases. So the conclusion of this practice guideline, we strongly recommend that exome sequencing and genome sequencing be considered as a first or second tier test for patients with congenital anomalies, developmental delay, and intellectual disability. So a couple of things that I wanted to pull out from this paper that are things that I haven't talked about thus far are the questions of cost effectiveness and equity. So they acknowledge that exome sequencing is more expensive than most of the other tests that you would be using. However, using exome sequencing as a first tier test yielded more diagnoses at a lower cost than using exome sequencing only after extensive standard testing or using standard testing alone. So if you aggregate all of the other tests that we could do, the exome sequencing actually is the more cost-effective approach. The cost per diagnosis is lower than if we start with the tests that are a little bit cheaper, but they have a much lower diagnostic yield. On the question of equity, I wanted to highlight this statement at the bottom here. Given socioeconomic status-based inequities in access to care, clinical experience suggests that if a diagnosis can be made in fewer visits, increased use of exome and genome sequencing should increase equity for patients with genetic disorders. So I like to use a little back of the envelope calculation, and I want to emphasize that there are a lot of assumptions that are made, but this helps me to kind of think of at least the orders of magnitude or kind of the relative multiples of cost of these varying approaches. So for Fragile X testing, let's say we have 100 patients with moderate developmental delay. So a couple of the assumptions that I want to highlight here. One is that the yield is higher for moderate developmental delay than it is for mild developmental delay. The yield is also definitely higher for developmental delay as opposed to autism. So a patient whose delays, so developmental delay meaning more cognitive or gross motor types of delays, as opposed to concerns that are more kind of social communication, behaviorally focused, that is a lower yield scenario. So I'm talking about a relatively high yield scenario here, a patient with moderate developmental delay, kind of global delay. And these costs that I'm showing here are estimates. They are going to vary depending on the contracts between hospitals and labs. They're going to vary based on the exact details of what's ordered. But I think these are reasonable, kind of middle of the road estimates for what the cost might be for these tests. The other thing that I'll say is that I tried to be generous in my estimation of the diagnostic yield of Fragile X testing and metabolic testing. So the literature about what the yield is of these tests is very, very subject to ascertainment bias. So you can dramatically change the perceived diagnostic yield of a test by just ascertaining cases in a more high yield way. So I don't think that the yield of Fragile X testing is actually 2% in this setting, but I want to be a little bit conservative in terms of these estimates. So if the yield is 2% at a cost of $250 per test, then the cost per diagnosis is $12,500. For metabolic testing, if we look at both those first tier and second tier recommendations from the treatable ID algorithm for metabolic testing, the yield of that might be 2%. Again, I think that's a little generous, but at 2% yield and $1,500 per evaluation, if you add up the cost of all those metabolic tests, that would be $75,000 per diagnosis. Chromosomal microarray at a 10% yield and $1,000 per test would be $10,000 per diagnosis. And exome sequencing, as long as it includes CNV diagnoses, I'm adding the 10% yield for microarray to the 36% from that meta-analysis that I showed you earlier. So if that's used as a first tier test, then the yield in the setting of moderate developmental delay, again, the yield will be lower in mild developmental delay, lower in autism. But for a patient with moderate developmental delay, a 46% yield at $2,000 per test would result in a cost of $4,350 per diagnosis. Now, the part that I haven't added here, this is just the first step, right? So if you did Fragile X testing, metabolic testing, and microarray, you would still only diagnose 14% of patients. The rest of those patients, you're still going to want to do exome sequencing. So then you can add these costs up And again, my opinion, looking at these data and these costs, are that the most cost-effective approach is to use your highest yield test first, not to use your highest yield test last. So, to me, this is additional evidence from a resource utilization perspective that I really do think that this is the right approach. So I did touch on the question of equity and access to care. And so those of us in the Mountain States region here, we cover a large geographical area. And so I personally see a lot of patients in Grand Junction and Durango, in addition to in the Denver metro area. And I can tell you that it's pretty hard to get metabolic testing done, and it's particularly hard to get it done under the conditions in which those tests are interpretable. So making sure that a patient has a blood draw without a tourniquet, and making sure that their fasting time is appropriate relative to the time of the lab draw. Getting urine from a baby girl, all of those things are very, very difficult, and those are barriers to diagnosis. And if we say that we will only do broad and high yield testing after we've ruled out metabolic disorders, that can be a really big barrier, and that can prevent a lot of patients from getting through the diagnostic algorithm to the high yield tests. In addition, there's attrition of patients at every step in the chain of referrals and testing. So we lose people out of the stream of patients who are moving towards a diagnostic result. Exome sequencing can be done on a buccal swab. It's a stable sample. It can be mailed to a patient's house wherever they are. They can do that collection at home, mail it off back to the laboratory. That removes a huge barrier to care. That removes a huge barrier that's preventing people from getting diagnoses. So even though that seems like a small little piece of all this, that the testing can be done on a home collection of a non-invasive sample, I think that is understated as a really important element in this whole process of making sure that patients do get diagnoses. That's actually a surprisingly big piece of all of this, is that sample collection piece. I should say that significant barriers still exist. So the biggest one that I hear about, and the biggest one that I deal with in my own day-to-day professional life, is payment. So a lot of payers don't see these data the way that I see them. We get the response that exome sequencing is experimental and it can't be covered. And it doesn't matter how many dozens of papers that I provide. So there's a lot more evidence than what I showed you today, and it can get pretty exhaustive to go through literally dozens of papers that support the diagnostic yield and cost effectiveness of broad genetic testing. But for, I think, mainly historical reasons, exome sequencing or genetic testing is kind of considered to be exceptional and different from other parts of diagnosis in medicine. And there are significant barriers to payment for these tests. One of the things that has helped in that regard is that some of the testing laboratories have taken that burden upon themselves. And so that does allow patients to have more transparency in terms of the expected cost of a test. That also allows physicians and clinics and hospitals to offload the risk and the burden for the financing or the payment of these tests, and to outsource that to a discussion between the lab and the payer. That still is not a foolproof process, but that has really helped to improve access. So that's something to look into if maybe you're interested in implementing some of this testing in your clinic, but you feel like payment is a barrier. one of the things to do would be to have some discussions with some of the genetic testing labs and see what they can offer in terms of taking over as the intermediary to try to get payment for these tests. Another barrier is interpretation. So the interpretation of these results has gotten more straightforward over the years, but it still can be daunting if you don't look at this type of testing very often. Sometimes the test results that you get can be confusing. You might get these results back and not know how to convey that to a family. That can be a pretty stressful circumstance to be in. So that is, there are some ways to alleviate that. So this is one of the big pushes for Mountain States to get more telehealth, so more ability for patients to be seen who might be geographically remote. And I think it's also on us as genetics clinics to figure out ways to have a higher throughput and figure out ways to take in these patients who have had outside testing to at least provide an initial interpretation to support the primary care physicians and the other providers that are ordering this testing outside of the genetics clinic. That's one of the ways that we're going to increase access to care and increase equity. I really appreciate you all listening to me talk about this. And I did want to leave a good chunk of time here to have a discussion among this group about how this information is relevant to your practice and any questions that you have for me.
Thank you so much, Dr. Larson. We really appreciate it. That was a great overview. And we are going to moderate questions via the chat. So I've just like to ask if anybody does have questions for Dr. Larson to type them in the chat, and I will be sharing them from there. And we do have our first question here. Do you recommend that a patient who had a non-diagnostic WES about 5 years ago undergo repeat testing or whole genome sequencing for improved sensitivity? This refers to a family with 2 children with hypoglycemia, liver dysfunction, and developmental delay.
That's a great question, and that's a topic that I didn't touch on, which is how is this test changing over time? So is exome sequencing in 2021 different than exome sequencing in 2016? And the answer is a resounding yes. So the test continues to improve in terms of sensitivity for a number of reasons. One is that a lot more genes are known to be associated with genetic disease now. And so the databases of kind of what are the reportable genes, those have increased dramatically. The other thing that has dramatically improved is the amount of genotyping that we've done in a reference or control population. And that has really allowed us to have better specificity in addition to the better sensitivity of identifying more disease genes. So for both of those reasons, it's gotten better. Those are all on the interpretive side. In terms of the chemistry and the actual like sequencing reactions, those are better. So there's more coverage of genes. There's better depth of coverage that allows for more accurate just calls of what is actually present in the genes. So I generally have an approach of if it's been at least a year, I will do a reanalysis. If it's been about 3 years, you often can get additional yield by repeating the test and doing a whole new test. Now the question is, should that be a whole exome sequencing or a whole genome sequencing? The data are, the way I would think of whole genome sequencing is that for right now, it's a relatively small step up in yield. So it might be like a 10% of patients who are undiagnosed for exome sequencing are diagnosed by genome sequencing. So that's a relatively small step up in yield for a significant step up in cost. So that's one way to think about it. But over time, that gap is going to widen just because of the ability to call things from whole genome sequencing that we can't see from whole exome sequencing. So to answer Dr. Nelson's question, for a patient who has a very compelling phenotype, I would say that it's probably time to revisit genetic diagnostics for that patient.
Great, thank you. And I see one of our Time for Genetics clinics has written in, is there a role of retesting Enigma kids, syndrome unknown to get sequenced?
Yes, so that's kind of the same topic of what's the role of revisiting these tests, and they continue to get better over time as we switch to whole genome, and then as we develop more of an ability to interpret the genome-wide data as opposed to just the exome data. Then yes, that will there's definitely a role for revisiting those undiagnosed cases.
Thank you for clarifying. And then I see a question here. Would you change testing recommendations if one or both parents are not available for a trio?
No. So, most of the yield is in the sequencing of the proband. There is some additional diagnostic yield if you can do a duo or a trio. But most of the yield is just in that testing for the proband. So, and that the gap between trio testing and singleton testing is narrowing over time for the reasons that I talked about, that we have a better and better database of both what's known to be normal or known to be present in the general population, and we have a better and better database of what's abnormal or diagnostic. So as both of those databases improve, the gap between trio testing and singleton testing gets narrower, and the singleton testing grows to encompass more of the diagnostic yield of the test.
Great, thank you. And I do see two more family parental questions, and I know we're not answering based on giving any medical advice here today since a doctor-patient relationship is not established, but could you maybe answer in general cases of an adult child with PDD, NOS, and mental health diagnosis, and whether an exome testing might be done today to get clarification on diagnosis now that that individual is an adult?
Yes. So in general, for patients with PDD, NOS, or autism spectrum diagnoses, the yield of testing is significantly lower than intellectual disability in the absence of autism. The same, I would say, is true of mental health diagnoses. So that is a relatively low yield scenario for genetic diagnostics. It's important to note that low yield is not zero yield, right? And some of those diagnoses can be very high impact. So I can't really say like what is the threshold, what is the expected diagnostic yield beyond which testing is or is not warranted. I would say, in the setting of a younger child with global developmental delay and not autism, that's a scenario where I would expect to be able to diagnose at least 50% of patients with a genetic diagnosis. As we move along the spectrum from there towards autism, and maybe from autism more towards more mental health diagnoses, the yield goes down. So there are some papers showing the yield in autism is about a fifth of the yield in developmental delay without autism. And the yield in psychiatric diagnoses in the absence of developmental delay is actually even lower than that. So there's then a value call, a judgment call on the part of the family and the providers to decide, is that a use of resources that I want to implement based on the expected yield.
Great, thank you. And I see a couple more popping in here. What is the yield of the microarray after gene panel if the CNVs are not included?
Thank you, Dr. Nolan. Thanks for being here. And I would say that it's, so in the setting of a child with moderate developmental delay, I would expect an overall 50%, roughly 50% diagnostic yield. 10% of that is going to come from copy number variants, and the other 40% might come from sequence variants. So if copy number variants were not included in the initial sequencing test, then you might expect 10% yield in that scenario for microarray.
Great, thank you. And maybe we'll do just one more as we wrap up here. If exomes suggest a large deletion duplication, would you follow up with microarray?
Thank you for that question, Susan. Happy to see you here. I generally do not. So, my experience over the last 3 or 4 years with CNV calls from sequence data has been good enough that that I feel pretty confident in those calls at this point.
Great, thank you. Do you mind if I share my screen over yours, Dr. Larson, for some last minute wrap-up slides?
Yes, go ahead, Christy.
Thank you. All right. We are putting the evaluation form today in the chat. We posted it in there just before the Q&A, but we are going to be putting that in just momentarily. So if you can take a minute to complete that form, it is mobile friendly to evaluate today's webinar. We really appreciate that. And then also, some of you have asked about CME, and we just want to let you know that we will be following up with an email to all attendees who are interested in claiming CME credits today. Stay tuned on that. We just have a couple other logistical things we need to do on our end with that. So those who are interested, we will be following up with that form via email. And so with that, I think we'll wrap up and just thank you so much, Dr. Austin Larson, for your presentation today. Thank you for everyone that attended. I saw we were up to about 69 or 70 attendees at one point. So thank you for everyone who came today and listened in. I got quite a few questions about a recording and slides. And it is our plan to put this on our website. Dr. Larson has agreed to share his slides with us. We did record it today, and we are pursuing CME credit for enduring material, meaning that you can share it with your colleagues, they can watch it afterwards, and hopefully be able to claim that CME as well. So if anybody needs to reach out to Cody or I, you can reach out to us through our website. But we really appreciate your time today, and we will be having one of these webinars every 4 months. So if you are not connected with Mountain States, please visit our website and click the Get Involved form and connect with us. With that, I will just say thank you to everybody and have a great day. Bye-bye.